that the checklist has had a positive impact on patients, and what's the best way to do this. So I want to talk a little bit about the nuts and bolts of, so we talk about checklist measurement. So you can measure, are they doing it or not, how well they're doing it, are they bought in or not, using that checklist tool. So you know how frequently they're doing it, you know what parts are doing, what parts are doing well, what parts are not doing well. But what's the best way to measure the positive impact on patients? And so I want to propose two ways of looking at it, or three actually. You can collect stories, which I think is incredibly important. You can use the debriefing and see what you're learning out of the debriefing, because the debriefing done well is going to help you fix equipment, avoid problems downstream, and make sure that specimens are labeled right and that the patient gets passed off to the next area of care in a proper fashion. All those things have significant potential effects on patient care. And then the last idea is to repeat the culture survey at some point in time. You know, one of the reasons why we encourage everybody to do the culture survey in the first place is to let them know, have a snapshot of where they are now. But we wouldn't be doing that if we didn't believe that if you put the checklist in place and get it firmly embedded in your culture, that over time, what problems you see in the culture survey actually have a pretty good chance of getting better. That's one of the reasons for doing this work in the first place. One is to improve patient safety, hopefully immediately with the use of the checklist. But the other piece is to change the way that people feel about the environment that they work in so that the culture around safety in your operating rooms actually improves over time. So you can measure, did the checklist do something by looking at the culture survey again a year from now. Now, let me go back for just a second and talk to you a little bit more about collecting stories. Because that checklist observation tool is a great way to collect some of the stories. But there are going to be other stories that are going to come out of using the checklist that tool might not catch. And we know for sure you're not going to use that tool in every single case that you perform in your institution. But there are going to be other times when the checklist is going to do something good. And what we think that you ought to do around that is to thoughtfully and carefully try and capture some of those stories. Some places that we've worked with in the past have actually recorded those and posted them in a break room, or posted them in the halls of the operating room, or posted them someplace where people can see. But keeping track of those stories really is probably one of the greatest ways of measuring impact on the care that you actually give in your hospital every single day. It can be captured in those kind of stories. Because the last thing that I want to talk to you about around measurement is about outcomes. And everyone is drawn to this. And I'll be honest with you, one of the reasons why we believe that the checklist is such a great thing to use in a hospital is because we know, because we've studied it now and other people have studied it, that used properly in a hospital, it can lower complication rates and it can make patients or help patients who might have died from an operation actually not die. I mean, those are incredibly important things, but that comes with some cautions, and that's what I want to talk about. Measuring mortality in an individual hospital, because a lot of people want to look here, and I want to talk to you about the dangers of that. Mortality in most of your hospitals, I'm going to guess in every hospital in the state of South Carolina around surgery, is low. And if it's low and you're not doing a bazillion cases, seeing changes in that can be quite difficult because deaths don't all happen, in a very regular way. They tend sometimes to clump, or they tend to be very scattered and separate. And measuring, especially over short periods of time, is really, really dangerous when stuff doesn't happen very much. So I personally try to discourage people from looking here unless you're in a really big hospital and you're committed to look over long periods of time, like year at a time. You know, people want to follow this stuff from month to month or quarter to quarter, and in most places it just plain doesn't work. There's too much variation to be able to see the change. So I would discourage you from thinking about that. But if you're from a hospital that does a lot of surgery, and by that I mean 10,000 or 15,000 or 20,000 cases a year, and there aren't very many hospitals like that in the whole country, this is probably not a place where you should go. Having said that, I went back to all the studies that have been done so far, and I looked at if we were to translate what they talk about in terms of mortality reductions in hospitals like yours, what are we talking about? Well, generally, you're talking about a difference of about 1 patient in 1,000. Now, that's not a huge number, but it is a life. It's not 1 in a million. It's not 1 in 10, and it isn't 1 in 100. But for 1 in 1,000 people who walk through the front door of your hospital, this can mean the difference between them walking home and not leaving at all. And we know that now from other people actually studying it on a large scale. We don't think you can do that in most hospitals in the United States or in South Carolina. Then I want to touch a little bit on measuring complications in an individual hospital. There are a number of ways to do that. One of those things, if you think your surgical site infection rate system is good, you actually can follow that over a period of time, but again, you need to look at large blocks of time, 6 months or a year, because it takes a lot of cases. If I went back, I looked at what we know about the checklist, and the checklist should help us stop 4 patients in 1,000 from getting an infection that they would have otherwise gotten. Now, that's not 1 out of 10. It's not 1 out of 100, but it's still a lot considering the amount of surgery that's done in the United States or in a state. And it makes the whole thing worth pursuing because as good as the antibiotics are, the checklist can be like a free antibiotic and prevent an infection in 4 out of 1,000 patients.